Let's go.
think that's a good strategy.
Stop telling secrets about people on the phone.
Managers are connected with you, do you know, here?
Here, I don't think so. Mostly our interaction is with down there since we don't have a local phone.
Okay, hi folks on the phone. Can I get a hello from someone to know that you can hear us?
Good morning.
Thank you so much. We are going to go ahead and get started. Thank you everyone for coming today. Just really quick housekeeping. If anyone needs the bathroom, it's right around the corner out that door and to the right. If you need the Wi-Fi, the password is right there. And for folks on the phone, I just want to let you know that we're going to make a solid effort at the end of each section to pause and check if you all have any questions. But if you do want to interrupt or share something in the middle, feel free to type your question in the chat box and we will pause and make sure we can get it addressed. Other than that, we are ready to go and I will hand it over to Allison.
Well, good morning, everyone. I am so glad to see a good, full house. We had some big movement over the last month in terms of identifying some leaders in the community to help us sort of push this work forward. So I am so excited to announce that the board has endorsed, appointed, betrothed the ACH Leadership Council co-chairs to Jack Davies and Pam Teets from the Spokane Housing Authority. Pam is getting ready for this really ambitious work she has ahead of us by skiing for the week. So she sends her regrets and will be joining us in the future. I thought I would be nice enough to say, no, you don't have to cancel your vacation for this very important work, but you should come back refreshed. So Jack, I want to introduce to the group. She's going to be our fearless MC for today. I know probably everybody in this room knows Jack from her incredibly distinguished career in all things related to community health. She was one of my early connections when I first moved to Spokane and has been such a trusted partner to me, being able to see calmly and strategically some of these most interesting connections between the healthcare system, social determinants of health, public health, and just an all-around fantastic person. We have ended up in a lot of meetings together, and we like to say I'm the loud one, and she's the very steady one. So delighted to have her. I'm going to turn it over to her.
Well, thank you, Allison. And I'm thinking that distinguished career is a euphemism for very long. So for those who may not know quite as much about my colored or colorful past, I'm currently the executive director of the Northwest Rural Health Network, which is the group of 15 rural health systems here in eastern Washington. Before that, I worked for many years at Inland Northwest Health Services, running a number of different community-oriented programs. And before that, I was with the Washington State Department of Health for a long time. I consider myself still to be, at heart, a public health person because I always go back to population health and always go back to data. I just can't get away from data. Very thankful, very appreciative of the board and and Allison, but altogether for entrusting me with being a co-chair of this group. I'm looking forward to working with Pam and with all of you. I see this as an important point in the transition from all of the planning that has been going on over the last 2 years to this is getting real as we move into some of the demonstration discussions we're going to have a little bit later this morning and some of the opportunities that we've got as a region. This is really where we as members of the community have the chance to start having an effect and having impact. So with that, I'd like to get started on a round of introductions. We always have sort of a varying cast of characters who come to these meetings. So we can just start right here. And in terms of making sure the people on the phone here, I'm going to just do a little bit of coaching on microphone etiquette. I think it works best if we just kind of make sure that this is close to the person who's talking, and if the light is green, it's on. So with that, we can start.
Hi, I'm Dawn Sayers. I am the Better Health Together Regional Coach Connector with Qualis Health in this area.
Hi, I'm Mike Weiser with Jazz Health, and I'm standing in for Aaron Wilson today. Ron Poplowski, Kalispell Tribe.
Layton Kimball, 18 and long-term care and Better Health Together board member.
Kathy Pham, Community Minded Enterprises.
Cindy Hochberg, Community Health Plan of Washington.
Amber Johnson, SNAP. Lilia Thurgana, Operation Healthy Family.
Pam Almeida, GSC Meals on Wheels.
Philip Tyler, President, Spokane NAACP and Better Health Together board member.
Good morning. I'm Jessica Pacotes. I am with the Kalispell Tribe Camas Path program, and I'm also Better Health Together board member and the Empire Health Foundation board member.
Good morning. I'm Becky Bates, Executive Director of Passages, and we do outpatient public mental health in Spokane County.
Good morning, I'm Kathy Olson from Molina Healthcare.
I'm Dan Sigler, Regional Director for Pioneer Human Services. We do housing, treatment, and employment for people involved in the criminal justice system.
Good morning. I'm Lois Bernstein with Multicare Health System. My first meeting. I'm happy to be here.
Good morning, Julie Honkamp with SNAP.
Kat Latte, Community Health Plan of Washington.
Paul Dillon, Planned Parenthood of Greater Washington, North Idaho.
Sarah Bullock-Dorn with United Healthcare.
John Roll, I'm the Vice Dean of the New College of Medicine at Washington State University and Associate Vice President of Health Sciences for WSU.
Great. And I'm going to introduce you two later, so we're going to actually go back to here.
And I'm Alex, and I'm
Mike Lopez, Integrated Health Services Manager with the Spokane and Spokane Valley Fire Departments.
Thanks, everybody. And if we could go around on the phone, and if, actually, I'm going to, let's see, we've got Jenny Smith on the phone. Jenny, if you could introduce yourself.
Yes, hi, I'm Jenny Smith, Newport Hospital and Health Services, Marketing and Foundation Director, and I also help with our Ponderay Health Coalition up here.
Great. And Peter Adler, if you could introduce yourself. Peter might be on mute, or might have been muted.
I am muted.
Oh, oh, you're free. All right. And Carly Levitz?
Yeah, good morning, everyone. My name is Carly, and I'm with the Center for Community Health and Evaluation. And my colleague Erin and I were at the Joint Leadership Council and board meeting last time. So I'm glad to be back, though this time by phone.
Great. And is there anybody else on the phone that whose name I didn't call? All right. Well, with that, then we're going to move on. We're very fortunate to have some guests this morning who are going to be talking with us about the importance of being able to plan healthy families. And it's obviously an extremely topical discussion point, and we're fortunate to have them. I'd like to introduce Valerie Tirico and Catherine Harkins, and they're going to tell you a little bit more about themselves. Okay.
I think we're both on now.
No, mine's on. Sorry.
Yours is still on, Catherine. Okay, now? Okay, it seems like they're either both on or both off is the problem. So let's try the hand mic. Okay. How's that?
Good.
Sorry, quite the intro. I'm Valerie Tirico. I'm a psychologist by training, former director of the Children's Behavior and Learning Clinic at Children's in Seattle. And this is my colleague, Catherine Harkins, who's a clinical nurse specialist nurse midwife. I always kind of get the acronyms wrong. And we are currently partners in an advocacy org in Seattle called Resilient Generation, focused on how to help parents give their children the very best start in life by optimizing birth timing and spacing and preconception care. We got involved in the Medicaid transformation process at the request of Bob Crittenden, Jay Inslee's Senior Health Policy Advisor, because even though the maternal and child component of Medicaid transformation and it is not a mandatory project through the ACHs, in fact, it is a high priority for the governor, and he is keenly interested in in making sure that people are aware of the way that it fits into the priorities around improving healthcare outcomes and at the same time reducing both centers of suffering and centers of cost. So that said, we're going to jump in. We're going to take just 10 minutes to kind of give you some information that we think might be helpful for you as you think about how to prioritize your time and energy.
The right arrow.
Got it. Okay, great. Hi. I'm just going to start out talking a little bit about toxic stress. I have a feeling many of you, if not all of you, have heard about the ACEs studies, the studies of adverse childhood events. And this is all based on, as you may know already, the biological embedding of stress, that is stress hormones actually changing the body and creating illness. It can lead to, the exposure to toxic stress can lead to chronic behavioral health issues, depression, chemical dependency, as well as physical or chronic illness and poor outcomes such as low birth weight, for example, but also to obesity, diabetes, and heart disease. And exposure to toxic stress can happen at any point in the life course, but does happen. There's more recent research that supports this in utero and actually likely even epigenetically, which you may also have heard. Toxic stress, the studies that led to this research based on ACEs were all done by Drs. Anda and Belletti. And one of the studies they did that's not often cited was of adolescence and pregnancy outcomes. And it showed that high ACE scores correlate strongly with unintended pregnancy. So the more adverse childhood events a young woman has experienced, the more likely she is to have an unintended pregnancy. Chemical dependency can also be, as I mentioned, the end result or an end result of exposure to toxic stressors. And among women who are opioid dependent, there's a very high rate of unintended pregnancy. 86% is cited by the Center for Disease Control. In a recent grand rounds they did, again, some of you may have seen this, in which they strongly recommend preconception care, access to pregnancy intention screening and contraceptives to reduce the risk of unintended pregnancy and help people get healthy.
So all of you know, of course, that the focus on opioids and trying to reduce the impact of opioids in our state is a high priority as a part of this process that you are involved in. I think what we're wanting to kind of think about here is this relationship between the opioid epidemic and an epidemic of unintended pregnancy that has kids coming into the world with the odds stacked against them. I don't know how it is here in Spokane. In Seattle, for example, Swedish Hospital is literally thinking about building an additional ward to deal with the number of babies that are being born there with neonatal abstinence syndrome. And, there's across the country, as you know, in the context of some of the back and forth about this debate, there are people who are focused on somewhat punitive measures around women who are pregnant and who are abusing various substances. But the statistic of the fact that 86% of those pregnancies are unintended, they're unsought pregnancies, suggests that we really can intervene in this in a way that isn't about coercing people or jailing people, but it really is just figuring out how to get these services ahead of time so that they can actually align their lived experience with their pregnancy intentions and desires. So again, one of the things that kind of, as we talk about this cycle of ACEs, we all know that poverty is very integral to that, and that what we are finding is that among women, what kind of global health experts call it epidemic of unintended pregnancy, is very much disproportionately affecting women who are the most vulnerable, whose lives are brittle, and that in particular those women who are in the far below the federal poverty level. And then I'm sure you all have also seen the data that shows that early unintended pregnancy that increases the likelihood that a woman stays in poverty, that her children are raised in poverty, and that they then have, again, the cycle of increased poor educational outcomes, more likelihood of an early unintended pregnancy themselves, increased kind of contact with the criminal justice system, and so forth. So all of those things that I mentioned, many of them are kind of social and social determinants of health. So why focus on this as specifically a part of the ACH process, which is very much health-centered?
So one of the things I also wanted to mention is, thank you, that unintended pregnancy itself may well be a toxic stressor. And that we currently, although we screen in primary care for diabetes, domestic violence, depression, alcohol, tobacco use, we are not screening in primary care for pregnancy intention. All of those conditions and illnesses I just mentioned are more effectively treated before someone is pregnant. In fact, sometimes there are risks associated with attempting to treat in pregnancy with depression, for example. And prenatal care, although it's incredibly important, in many ways can begin too late to address some of these issues effectively, and exposure starts early to this whole stress hormone process. And so we miss a window if we don't emphasize primary prevention. This is a graphic from the Center for the Developing Child at Harvard, which is one of the leading national advocates for addressing toxic stress exposure and because of its effects on early childhood development. And you can see preconception it's really the earliest window in a sense of intervention. It also may be a moment in which we can begin to address a cross-generational cycle where a mother or father is exposed, and in the course of pregnancy, an infant will be born having been exposed.
So because of that, again, this may be familiar information, but the CDC has begun doing what they can to get out information with a focus on preconception health and preconception care. We now have data that suggests that both the toxins that a woman is exposed to and the nutrients she does or doesn't have during the weeks before she gets pregnant can have a lifelong impact on a child's health. And what you see down at the bottom of this slide is that even though we often talk about pregnancy timing and prevention in the context of women's health and et cetera, and that what you see down here is that it's really a bunch of folks who are very interested on giving children best starts in life that have kind of ramped up this conversation.
So what is the scope and significance in Washington State? The latest numbers show 37% of pregnancies are unintended in Washington, and that has decreased, but it's still quite a significant number. And as you look at more vulnerable populations, the numbers increase. 51% of pregnancies to women on Medicaid are unintended. And this, along with the cost and suffering, which I think we know is tremendous, there's also a financial cost. Unintended pregnancy costs Washington State $220 million, and over half of that is related to pregnancies in adolescents.
So I mentioned that this is very integrated with the cycle of poverty. If you look at this, one of the concerning statistics here is that over the course of recent years, there's actually been a widening disparity between women who have more resources and women who are lacking those resources. Part of that may be because they've been disproportionately hit by economic downturn, for example. Part of it may be that women who have more resources also have more access to information about trend, kind of life-changing, long-acting contraception that takes some of the worries out of it and takes some of the human error out of the equation. But the concern is that unless we kind of figure out how to address this, that we can expect that the ability, the differential ability to optimize birth timing and spacing is going to actually contribute to widening economic disparity at the time that we're trying to figure out how to narrow those gaps.
So what are potential solutions? One we think is quite important is increasing access to the LARC methods of contraception. They're the long-acting reversible contraceptives, IUDs, and implants. They are sort of the Cadillac methods of birth control in that they are so much more effective than, for example, the birth control pill. They have a failure rate of 0.5%, where the pill, sort of the most recent figures, and it's shown some improvement, is actually a failure rate of 7%, but likely higher for people who have very stressful lives. When in a single snapshot, that doesn't sound earth-shattering, but over the course of a lifetime, 30 to 35 years of trying to fend off pregnancy, those failure rates are really significant. The advantage of LARC methods are that they are set it and forget it methods, and they last from 3 in the case of implants to up to 12 years in the case of one of the IUDs, and it may well go beyond that. Valerie?
So one of the questions about these methods has been, and concerns about kind of methods, the long-acting methods, is that there are communities in our country, poor women, black women in particular, who have in the past been subjected, and sometimes still are, to pressures to kind of use specific methods. Sometimes people have actually been forcibly sterilized in our past, and so there are legitimate kind of anxieties in communities about getting some kind of contraceptive method that people can't totally control themselves. And one of the ways that that's being addressed is by really creating some woman-centered screening, and that is focused on this question. This is an Oregon model called One Key Question, and the one key question is simply, would you like to get pregnant in the next year? So that it's the person's own desires and intentions that are then driving service provision. And this is not only kind of woman-centered or client-centered, but it's also then providing a very simple model for integrating into primary care settings, chronic care settings, and adolescent health settings, this the kind of topic of birth intentions, birth desires, or parenthood desires, and then being able to address that.
So I think one of the myths is that contraception is easy to get your hands on. I think, unfortunately, the more effective the method, the harder it may actually be. Here you can see that there are over 20 million women in need of publicly funded access to contraceptive services. And for over 10 million women, they have actually essentially no access to public clinic with the full range of methods. That means it includes the LARC methods, the IUDs and implants. And there's a wonderful graphic that doesn't show up well here, but you can actually see the counties your ACH serves and see an indicator of access. And you actually have here, along with beautiful landscape, you have a LARC desert. It means a county where there is no provider that offers the full range of methods. And that's actually Lincoln County.
So part of the reason this conversation is happening now, part of the reason Dr. Crittenden asked us to kind of get engaged in the Medicaid transformation process, and the reason that folks like Jay Inslee are so excited about it is that there is kind of an unprecedented opportunity here. One is that cost barriers have been substantial for these methods that can they are cheaper in the long run over the lifespan, even without taking into consideration the cost of unintended pregnancy, but there's often a substantial upfront cost that can range from several $100s to literally $1,000, and the ACA's mandate, which may get reversed, but eliminates that barrier. Secondly, that the American College of Obstetricians and Gynecologists and then even pediatricians are now have given these methods a strong endorsement for all sexually active women, including teens and including women who are have multiple partners and who are HIV positive. So obviously there are some medical contraindications that need to be taken into consideration, but broadly these methods that are such game changers are now have the strongest endorsement from professional organizations. Secondly, I mentioned that we've got the public will here in the state. Third, or next, that there are now resources across the country. The Bixby Center at UCSF, for example, is one of those resources that has really done a bunch of work to figure out what does it mean for care providers, whether they're in small clinics or larger hospital systems, to upgrade clinical services and really retool not only the training of the providers themselves, but the billing and scheduling and everything else that is different when you're talking about actually doing a procedure rather than writing a prescription for a pill pack, for example. And then I will say there's also I can't go into details, but there's some strong philanthropic interest in perhaps coming into Washington State and providing support for that kind of upgrade here that could potentially get integrated with projects that are being done by the ACHs. It's not guaranteed, but I'll come back in and talk to the models and some of the folks who are working. We're going to mention a model in Delaware, are keeping a close eye on what's happening in Washington State.
I just want to add one thing to the pregnancy intention screening. I think Valerie may have mentioned this, but I want to emphasize it because there has been a lot of concern about the time required of clinicians, doctors, advanced practice nurses to do that screening. It doesn't have to be done by a clinician. It can be done in any number of ways by other trained support staff, and that can save enormous time and make the whole visit more efficient. Oh, I'm going to pass this to you, actually.
Okay. Sorry. So the most powerful of the models that I mentioned is what's happened in Colorado, and again, some of you may be familiar with it, with philanthropic funding, substantial philanthropic funding that was needed because they did this before the ACA contraceptive mandate kicked in. They did they worked through all of their Title X clinics in this case and made the full range of contraceptive methods available to all women, same day, free of charge, really aggressively working to minimize barriers to access. And what they found is that they've had now a dramatic decrease in teen pregnancy, and they've had a dramatic drop in their abortion rate in births to young women in their 20s who are single, because again, I think 70% of those pregnancies are unsought pregnancies. And then they're starting now to see the ripple effects as it affects the rest of their social safety net. And then this model in Colorado then provided the basis for the governor of Delaware going in and recruiting a nonprofit called Upstream to help them engage in a similar kind of statewide transformation process that they are then trying to expand so that it's integrated with services to all income levels. So I mentioned Delaware, CAN, and Upstream. The St. Louis study actually precedes both of those. It was, again, that they basically provided these services and with minimal barriers and really optimizing the flow of information so that people could make fully informed decisions. What they found in that context is that women who want to prevent pregnancy actually do care about getting something that is hassle-free, that they get it and forget it, and that provides them with the best protection possible so that they can have babies when they feel ready. And then what we have going on here in Washington State is that, again, some of you may already know about this, but the North Sound ACH has launched a demonstration project. They kind of got excited and got out in front with a project based on what they had seen from Colorado and Delaware, and are now in the process of doing a series of trainings that ensure that primary care providers in the North Sound region are able to have the skill set and the kind of information that they need to be able to upgrade services for the people they serve.
So what if we were to make these changes and suddenly intentional parenthood became the norm across Washington State? If we are able to upgrade care and make LARCs widely available, more widely available, and integrate these services along with the one key question and into primary care and behavioral health, drug treatment, we may well be able to do that possibly more rapidly than I think people might guess. I think I really want to emphasize that by addressing this issue as primary prevention, we can have tremendous impact on child health and development outcomes. Using the one key question and LARC methods to change that dynamic, to break that cross-generational cycle, then can amplify all the other work many of you are engaged in. If, in fact, it decreases the likelihood of developing diabetes, of developing a chemical dependency in heart disease, we're talking about rolling back both suffering and costs across a lifetime. I think even more importantly, we might be able to begin to, in a sense, reverse this cycle and start one that's really focused on building resilience.
So we'll stop there. I think we just wanted to, and appreciate that you all let us come here this morning and plant this seed, and so that you, as you move forward, can think about how this fits with the broad array of priorities that you have and how you might be able to amplify, as Catherine said, the other kinds of services that you're providing.
Any questions for Valerie and Catherine? Yes.
Yes. This is Phil Tyler. I wonder if in this data that you collected, did you find a link, as some have reported, between hormonal birth control methods, whether it be the birth control pill, IUDs, or your LARCs, and depression?
Yeah, there was I think you might be thinking of the Danish study.
Sure.
I think there's a fair bit of skepticism about how that study was done. I mean, we'd certainly say no method is risk-free. They are all much less riskier than pregnancy itself. And the risks around depression coupled with pregnancy overlain with other toxic stressors can really be, I think, is likely, I'd say, much more risky for child health outcomes than a single method. Does that make sense?
Sure. Thank you. And then my follow-up question is that,
yes.
I'll let you go ahead, ma'am.
Oh, so what I was going to say is one of the nice things about these top-tier methods is that there are actually, at this point in this country, we have 3 different options, and we're hoping that the array will continue to grow. One of those, the copper IUD, is completely hormone-free for people who have medical contraindications and or who are sensitive to hormones in ways that don't work well for them. And even the hormonal IUD it doesn't have the estrogen that is contained in many of the pills, and it has approximately 1/20th of the progestin that is in a combined oral contraceptive because it's a locally released microdose. And so there's again, one of the nice things about that is that women often can tolerate that who don't tolerate pills well. And then with that hormonal method, there are also some nice bonus health benefits, including some protection against some cancers.
Wonderful. And then the follow-up would be then, so part of this, and I'm going to assume it is a broader educational piece to these young women and women of color with regards to helping them inform what choice they should make with regard to this.
Mm-hmm. I think we want to emphasize that actually, for example, the one key question we think of as agency building. So it gives the person asked, and it actually could be asked to young men as well as to women, whether you would like to become a father this year, it actually gives, it's a chance to build autonomy. It actually is a check, because there are concerns around coercion, on having a choice. And it's important that all the methods are presented, and that is part of what's emphasized in the one key question approach, or the pregnancy intention screening approach.
So part of what's happened, you may have heard the term information architecture, and is that like there are kind of, it matters what order you present information in and how you present it. So, you know, one of the shifts that is happening is when a young woman comes in and says, I'd like to have some kind of contraceptive, rather than saying, oh, what would you like? And then she's like, okay, what's my aunt use? What's my sister use, et cetera. Or like simply launching into the most familiar methods, that the doctor, by using this, or other clinician by using this method, begins by leading with the things that are most likely to help her accomplish her goals, but that it always needs to be kind of centered in the preferences of the person.
I was going to say, just as if you walk into a physician's office and you're anticipating you're going to be offered the most effective treatment along with others, right? I think that's the same principle.
Yeah.
I work at Planned Parenthood, so this is great. So thank you for all the information you laid out. I was curious how you singled out Lincoln County as a LARC desert.
That was, I got that information from the campaign, the national campaign to prevent teen pregnancy and unintended pregnancy. Okay. And it was just released, and I know it could be inaccurate. So I would love to hear that is wrong, actually.
Well, yeah, only because I'd have to check everything, because we did open up a center in Moses Lake, which is right on the borderline, and we have seen an uptick in visitors, but I mean, we get patients coming over from Montana, so I think there's a lot more deserts out there.
Yeah, they are. If you go east, actually, you can see. That's true.
One more question here, and then I want to make sure we give people on the phone a chance to ask.
My question is related to the one key question. I was in Oregon when that was moving through the legislature, and so wanted to see what our approach is right now within Washington to approach the one key question in a statewide model. I think it's important that it does come through a regional approach or sort of a grassroots movement, but also I know that in Oregon that was moved through at a statewide level as well. So just wanted to see, with Jay Inslee's support, is he moving that approach forward through legislation or those sorts of things?
I think the governor's office is feeling like they want to make sure that this information is out and available, and they're trying to take a somewhat hands-off approach and not tell people what to do. That's kind of what I've heard from them. There is a lot of enthusiasm around this idea in Washington State of routine screening for pregnancy intentions, because we routinely screen for some things that actually affect a much smaller percent of lives, and sometimes in a less, in a genuine and important way, but in honestly a less significant way than this might or could. For example, in King County, they're now doing some research to look at the appropriateness of this kind of screening with teenagers who are sexually active, and trying to figure out what are the age limits around what it fits and how you would ask those questions. There's Lisa Caligari at the University of Washington is working with folks at the VA to kind of generate, in Seattle, to generate kind of a routine screening method that fits their population, and that they might be able to use via a waiting room app rather than to having to take clinician time, so that then they kind of come into the clinician visit knowing kind of what questions the person has and where to go from there.
Thank you. And any questions from anybody on the phone? Or anything in the chat box?
Yes, this is Peter Adler. Are you able to hear me?
Yes.
Terrific presentation. Thank you. Peter Adler from Molina Healthcare. My question is about the disparities across the state of Washington that you mentioned in terms of access. And if you could comment any more about this particular region in northeastern Washington, relative to other parts of the state. Your assessment, is this a particular, this disparity particularly greater in this region than others, or are we about, or are challenges and problems in this arena pretty much the norm in this state? Thank you.
So in the North Sound Accountable Community of Health, I can't, Catherine may be able to speak to the rest of the state better than I can. There was a survey done that is not, it's not public data, but that what came back out of that survey in the region was that less than 10% of the providers who said that they provide family planning services actually had the capacity to provide the top tier methods. So that was part of what focused them in and convinced them that they wanted their demonstration project to focus on increasing capacity. In Delaware and Colorado, a significant component of what they did was they first increased supply and then worked to kind of on the demand side by kind of doing a public education campaign in each place. Delaware has now finished most of their training. They're just launching that public education campaign. And I know from the State Department of Health here that they're saying we are actually ahead of where Delaware started out and where Colorado started out, in spite of the fact that you're hearing that there's still a lot of room to go.
I would just add that the campaign shows that it gives a county map that there is, I mean, I think also it can actually be misleading. You have 3 counties that show 1 provider for the entire county that provides ARC, but the density is so low that it's done by ratio. You can see where there might be a sort of gap there. But I think Spokane certainly is sort of higher on the list in terms of providing, and there are a number of centers here. And there are a few others. I think that it's sort of spotty. I think half the counties have moderate access and half have close to no access, based on what I've seen. And again, it's confusing because it's done by county map. So that might be a limited impact. Thank you so much.
Thank you. Again, terrific presentation. Thank you.
Time for one last question on the phone? Or let me see if anybody else on the phone. Okay, Mike, I'm going to run you the phone over here, and then we need to move on.
Okay. Thanks for letting me ask my question. That was great presentation, great information. Hopefully I can articulate my question correctly. So within the Spokane community, despite the fact that we have fairly robust services, there's a certain percentage of the population who either don't know how to engage with the healthcare system or, for whatever reason, avoid engaging with the healthcare system until it's an emergency. So do you have strategies on how to approach that percentage of the population?
It's a challenge, isn't it? So I guess I'd just say a couple things. One is that, for example, in Delaware, they are explicitly taking what they call a no wrong door approach within the healthcare system. So really working to make sure that these questions get asked and women kind of are focused, or young men are focused on kind of directed to the services they need, whether they come into adolescent care, chronic care, et cetera, including integration into labor and delivery, because ironically, that's one of the places where conversations about birth spacing and about kind of what does the next year and a half hold have been actually left out oftentimes. There have been some questions, I think, like the one key question folks from Oregon are now doing consultation with March of Dimes and trying to kind of think about how they might actually integrate open doors into some other kinds of social services. In Seattle, there is also now a national model that is, and I realize this isn't kind of culturally possible everywhere, but that they have created now a national model for ensuring that these services are available on-site in school-based health clinics.
And they have had a really significant drop in teen pregnancy, 15 to 17-year-olds in King County. I was just going to add that another way to approach this can be through community health workers as trusted messengers. They obviously can't provide the clinical service, but they can screen and they can offer the right information. and they could then help make appointments for people. It's just one alternative way.
Great, thank you so much. And again, we can just do a round of applause for our speakers. And actually, the mention of community health workers is a great segue because we're going to be starting to talk now about, after having heard one great example of a project that could be incorporated into an ACH portfolio, we're going to be talking about the project selection process here at Better Health Together, and maybe turning it over to Allison.
We're going to try over the next couple of leadership councils to do, I don't know if it's quite a commercial, but almost a commercial on potential projects that the region could consider. I really appreciate Valerie and Catherine's time. We've had some really engaging conversations over the last couple of months where just the light bulb starts to go on as we think about how important reducing ACEs has been to bringing most of us around the table. And when we look at the Medicaid waiver and the demonstration projects, it is clear that there's a lot of interventions that we're actually talking about, and yet we know we need to do those so that we can get upstream. And so I hope our region really anticipates some of these projects that could get us closer to upstream and prevention as we move forward. So there's my 2 cents on that. I want to spend just a little bit of time talking about our project selection process. We're really excited. The state has submitted their project protocols now. So we've got the full agreement, we've got the terms and conditions set, and now the protocols are back at CMS getting ready for final approval. So I think we're getting close to things feeling final on that side so that we can really get to work. There have been some evolution to the transformation goals, so you'll start to see these often. They're not dramatically different. I think there's just some specificity in there that is really helpful. Specifically, the emphasis around value-based payment and reducing costs. I think as much as many of us may be motivated by the heartful and the like, it's the right thing to do part of this, we've got to be able to balance that with some payment-related activities. This gives you a quick update on our timelines. Each week, I think I get a little bit more detail and go a little bit deeper on how fast stuff is gonna move. Each ACH will need to go through a phase 1 certification process, and I'll give you a quick rundown on what that is by May 8th, which is just a few days from now, it seems like. In early May, the Healthcare Authority will formally release the project templates that will be required to complete. And so we envision between June and probably late September the actual technical development of these projects in there. And so that is not a real long period of time, especially when we know that some of the components of those project templates are going to be population effect, ability to measure population outcomes, and funding return on investment. And while many of us in the room, and there are some rock star fundraisers in here, know how to do a really good back of the envelope return on investment, the kind of financial analysis that's going to be required is going to be great. So I just want to add a little stress to everybody else's life since I'm holding that one deeply. The first, one of the good things I think about this waiver is that there is some administrative investment to make sure regions aren't trying to fully bootstrap this. They can't give us any more time, but I think we'll actually have some dollars to be able to support some of this work. So phase 1, each region will receive up to $1 million, which, that's a lot of zeros for a girl from the suburbs like me. once we have completed the certification process. And the core elements of this certification process will start to look sort of comparable to those of you who remembered our 147-page designation application. A lot of similarity there, with some further clarity based on what has been agreed to with CMS. So we're expecting to submit that in late April or early May to trigger that first payment. Oh goodness, there's one I wanted. So that leads us to, we've got a little bit of money to work with. We've got this timeline that we need to be ready to submit in early October to the state. And as we have gone through the discussion, and do I have the slide here? That's the slide I was looking. So if you remember this, we have some required things that we have to do, and then we have some optional projects. And we did a sort of gut check with our BHT board in January after spending, I don't know, some ridiculous amount of time, like 2.5 hours walking through each of these different areas of, do we envision going for everything? Do we envision being focused? And there was sort of a good amount of discussion around, we should probably be sort of focused on this so that the region earns the maximum amount of money, and that I think we're all concerned about just the bandwidth capacity on the provider and on the social determinant of health side of things. So we had sort of no decisions. I want to make sure I'm being really clear. No decisions were made. This was just a, sort of thumbs up, thumbs down kind of thing. So this idea that, well, 2 optional projects seem right. And I will say from our ACH team standpoint, we're like, okay, that feels like 5 required things plus 2 optional ones. Like, okay, we can see how that works. And then we were looking at these optional ones, which are health equity through chronic disease, maternal and child health, oral health, community-based care coordination, transitional care, and diversion interventions. And I thought, wow, that's going to be a super fun conversation to have when I tell you, oh, we didn't select the thing that you're most passionate about and see as a key indicator. Nor could you really justify saying, so maternal and child health, we think that's really important, but it's not one of our priorities. And yet, we talk a lot about reducing ACEs. So we've sort of shifted our thinking a little bit in terms of, this is not about Better Health Together's bandwidth. This is about the region's bandwidth. And the essence of a health collaborative is how all of these pieces work together. And so I'm really excited about the process that we have we've laid out here to try and make sure, one, that we have a really good inventory of all of these models and what's happening in the region that we could be scaling up, and where there's been a capacity issue but yet a high interest in these various project components to be able to make a really smart decision so we end up with a real balanced portfolio of projects. And that we literally don't leave any money on the table. Because I think even though that time frame sort of scares the heck out of me, it will be so sad if come January 1 we think, we just worked a little bit harder and collaborated a little bit more, there could be more dollars available. So I'm going to talk you through this process, and then I'm happy to answer any specific questions that you have. So after the last Leadership Council meeting, we sent out a survey to everyone. I think all of 5 people have completed it. So we're not seeing you all, literally you people in this room filling it out, although I bet Lynn Kimball has, because she's a very diligent board member. But it's not only for leaders of organizations, but really your program staff as well, to get a sense of where there is community energy around this. So that's going to be an important piece. The second part is we have really played around with this idea of letter of interest so that we start to get an idea of where that capacity exists in the community that is not dependent on what the BHT staff or the BHT board knows, or even what you all know, that we're trying to push this out as far as we possibly can around the models that are reflected in there. So on the 30th, we will launch, everybody will get, and we would ask you to forward on as much as possible our letter of interest process. And we're trying to balance this letter of interest with enough depth of information so that we can really see how deep the capacity is. And yet, I know there's not one person sitting around this table who's like, and I have a lot of extra time to be filling out letters of interest. So we're working really hard to make it relevant to both our selection process and not overwhelm you, because this is really the idea generating portion. On April 8th, we will formally release the evaluation criteria. We're going to have a little activity next for you guys to give some feedback. For those of you who've been around, you will remember when the state did their sort of all-call tell us projects that would be cool for the waiver, BHT was the only region who took the projects from our region, moved them through a set of criteria, and then provided an endorsement of, I think, probably 70% of the projects that were submitted that would meet the criteria that we thought was important for our region. So we've got that as sort of a foundational. We want to spend a little bit more time with this group getting some feedback, hence it not being released until the 8th. But today you'll get to see sort of how we're thinking about that, so it doesn't have to slow you down in your idea generation process. Letters of interest will be due on May 15th. So again, trying to give you enough time and yet not forgetting that timeline that's going to be very, very, very quick. We will have a board evaluation team that will then identify selected proposals to move forward in our process. And the next step in our process will be our ACH Community Project Showcase, also known as Shark Tank internally. So we really want to have this as short presentations from these proposals to a broad group of interested parties, with the idea that it's much more of a pitch than a academic presentation on things. So it will be fast. We're working on Mark Cuban. That was a little creepy. From there, the board evaluation team will put forth a set of recommendations to move into our full proposal process, which will launch in June. We envision that team to be both from the folks who had submitted the proposals to that point and being able to access the Healthcare Authority's technical assistance team that they've hired, which is Manat, which is an international healthcare consulting firm, to really work through a lot of the data analytics and financial modeling that will be required. So while this early LOI showcase process, we want it to be taken really seriously, and we wouldn't imagine having different projects going into the summer work sessions than that, we also sort of recognize that not all of us have on our staff's financial modeling complexity or talent that we would be able to do that. So then for the summer, we would work to establish or complete these full project templates, and then our intent is on September 20th that the board would make a final decision on the portfolio. We're a little unclear of how many folks will go through this process and if this will just be the formal endorsement that these are the projects we're submitting, or if there'll be more selecting that'll need to happen. There's a little bit of gray area based on how many projects we have. And then the Healthcare Authority claims that by December 31st, we will know our projects and money will start flowing the first part of the year, and we will get to work in starting to earn those outcomes. We'll really have 4 years to demonstrate both cost savings and outcome improvements, and each year the amount of dollars tied to achieving of the outcomes goes up. So in the first year, It's 25% of your dollars to be earned would be based on achievement of those goals, 50%, 75%, 100%. So it is not a long ramp up period. So one of the things we know we're going to be looking for is projects that are ready to go January 1. So maybe I'll pause there and see if there are, of course, many, many questions. Yes.
Where do we as Leadership Council plug into this timeline?
So I would imagine you would be soliciting project ideas. You're going to give evaluation feedback today. You will be part of the showcase here. We'll have some sort of voting feedback mechanism. Some of this, I want to keep reminding everybody, like, this is a collaborative thing. This is not my process to you. It is our process together. So some of this stuff, TBD. And then I would imagine on these project teams, obviously folks from this group would be part of that.
So I wonder, are you still wanting feedback on the March 1st surveys? And if so, would you send that out again?
We will.
Okay. And then would you also be willing to share the slide deck with the timeline? Okay.
Absolutely, absolutely. In fact, as a general rule, maybe just as not even a general rule, like we just will, every time there's any kind of presentation, it goes out in the blast, and then it's always on our blog.
Great.
So connected to that question regarding the Leadership Council, would you see that the Leadership Council would have a role in recommending the decision prior to the September 20th board meeting? So in a recommendation of sort of, as we're looking at the board's final decision on preferred projects, would there be a role for the Leadership Council?
I think that's possible. I think I will commit to us coming back by the June meeting with some clarity once we know how many projects we're looking at. In some ways, I hope whoever's moving through the full process is the projects, and we're not actually at a point where there's as much negotiating on how much bandwidth there is, so that would happen there.
And I have one additional question regarding the LOI. So I think something that's important to, and this is Kat from CHPW, something that's important to keep in mind is the recognition of scale and spread of the projects. And so I think it's important that as we're communicating the LOI, that it's not thought of as potentially a competition, but the idea of how can the LOI actually be, to your point, the sort of culling out of projects across the region so that there's opportunities to really link those projects together to ensure that there is a scale and spread of those specific projects. So I think just figuring out ways that we can communicate that it's not necessarily a competition, but that it's an ensuring that there might be 7 LOIs that are trying to address maternal and child health. How do we pull out of there the components that really make sense together to move that project forward? Because I think as we start to get into scoring, the idea of scale and spread, number of providers and number of Medicaid lives served is going to be critically important to recognize. So just a recommendation regarding communication of LOI and project selection process.
I think I appreciate that, and Hadley, I hope, has written exactly that point down, because part of, I think, this line that we're walking right now is really looking at making sure we're getting these best ideas and we're making sure that it matches across the existing capacity, but not limiting ourselves to what the existing capacity is, because the whole point of this is actually transformation. And so I feel a little like we're doing this all the time. So I definitely appreciate that. I also think by trying to push the general thrust of the projects forward, that gives us this time between sort of May 15th and when we launch into the deep dive of actually completing the project templates, that pushing together this is really similar. And I would say we're thinking really seriously as ACH leaders around the state where there is capacity that if we were all doing something, you would have some built-in capacity on some of our partners who are in multiple ACH regions as well. So that's really a helpful point.
Actually, that's a really good point, where you might have cross-ACH border opportunities. And
are the ACH leaders looking at ways and on the timeline for how you might coordinate what projects seem to be bubbling up where there's shared populations?
Yeah, we're trying. We've got a couple of meetings of full ACHs to sort of start prompting some of that conversation, as well as I would say very specifically Better Health Together, North Central, and Greater Columbia. Linda and Carol and I are working really hard because we don't actually believe the ACH lines were drawn with a huge amount of thoughtfulness. When you look at, well, Lynn covers some spaces in different places, and Spokane Housing Authority covers some counties that aren't exclusively in our region, as well as just medical referral patterns, et cetera. And no movement from the Healthcare Authority to change the apparently Sharpie-driven drawn lines there. But I think it's incumbent upon us to really look at how that could work together. I think I'm really pleased we're clear about our process, and as others start to get clear about their process, we'll be able to overlay those pieces together in that way. But I think there's going to be a capacity issue, and for me, I feel like I got about 2 more weeks of like some broad community or statewide conversations before I'm all into this process, and like my goal is to earn as much money as our region can possibly do. John.
Allison, could you remind me again where these approved evaluation criteria will come from?
So ultimately the board, as the governing body of the ACH, will approve them. But our next thing on our agenda is for you all to give us feedback based on this criteria that we used a year and a half ago with our original project endorsement. A few tweaks based on some things that we've learned since then. But we've got an activity following this conversation specifically for you all to give feedback.
And a quick follow-up?
Yeah.
Monet and the state level groups, do they have input into that evaluation?
This is just for our region. Every other region will have a different process and or set of criteria.
But don't you want to be able to make meaningful comparisons across regions?
The models will be the same across, but the evaluation, the way this is designed, though I can tell you we all share everything, so it isn't as if there hasn't been some sharing, but the way the structure for ACHs is it's our region's prerogative to decide what our criteria is.
Thanks.
And some of them are connecting to what they're telling us. Sure. Ultimately, they will evaluate on. So there is some of that. Yes.
Yeah. So in regards to the previous conversation around the different ACHs and crossing boundaries, and it would be great if the Healthcare Authority could provide the different projects for each of the regions. So, we could look kind of across them all of what it is that folks are thinking.
Yeah, so the toolkit is the same for the entire state, and once we get to the point that we've all submitted, I'm sure they will develop that. Yeah. I think we see a real value in trying to identify those things sooner rather than later so that it informs our planning process, especially for our partners who are in multiple jurisdictions, and that I think one of my many, many concerns about this in general is for organizations who are cross-jurisdictional, there's only so many people to be able to participate in doing this. So if we decide LARC is going to happen in all 9 regions, let's take that off of we really need a specific local team to do that, but more, can we collaborate across? So I think who's interested in what sooner rather than later will be helpful, specifically for folks who are in multiple regions, but also I think in our planning to take advantage of other groups thinking and how we can sort of maximize the getting to those templates being completed.
I wanted to ask a question. Excuse me, Allison, because I have to leave early, and I apologize for that. Going back to the survey that you sent out, yes. and you suggested that you sent it out to all the community partners that are involved in the Leadership Council, but 5 have responded.
Yes.
But you stated this was a collaborative process. So, I apologize for our organization not responding to that thing, and I want you to, like the lady said here, to resend that out to us. Secondly, you alluded to the fact that you not only want these persons that are sitting around the table here to respond to that survey, but their members to respond to that?
Absolutely.
So is that something you want us to share?
Yes.
First of all, okay,
Yes.
Secondly.
There's no limit on, it's really not a formal scientific gathering. We're just trying to see where is there community movement and interest, so that if, as we move into this LOI process, we see folks that we're not aware of who are doing X or Y or Z, we can go out and make sure they know about the ACH, they know about the waiver, and be able to move folks into our process. So it's not just dependent on, you know, who shows up at this meeting or who sits on the board or what Hadley or Justin and I might know.
No, and I appreciate that. My concern is then that if we have these tens of community partners engaged in part of this leadership council, yet 5 individuals, one of which is in the room, and I appreciate whoever she is, you told her, right? I didn't say there was, have not responded. My concern is then going out with these letters of interest when we launch this. I want to ensure, at least from my standpoint, in going out and engaging with the community, that their voice is heard, and it helps to inform our next step, lest it be what it looks like to the community that a board of people with very little representation of people of poverty, people of color, save myself and my sister that's sitting right next to me here, don't have the added input that they need. And so I'm trying to look for clarity and specificity around how we go about doing that and engaging those that have been a part of this leadership council, but yet to have responded to a survey you sent out some time ago. Does that make sense?
Yeah, and a couple of comments on this. The good and the bad of the toolkit is in each of these areas, there are very particular models of which will be fundable through the waiver. So this is not a, I'll call what could we do. It is how would we take in our diversion intervention community paramedics, and what is currently happening, and how does that align with that model? There's not any place to say, well, we don't think community, no offense, community paramedicine is an important thing. Like this is, there are set models of which in order for us to earn dollars in there, you have to be using. So I think we need to think about the engagement process around Medicaid beneficiaries and giving feedback of how, when we're ready to launch these projects, how we make sure the engagement is appropriate. Yeah. But I'm not sure this is if you're not doing something in one of these models, the survey isn't going to make any sense to you. And we don't have the authority to say, you know, insert the best next thing that isn't listed here. The waiver can't fund that. The waiver can only fund the project models that are in here. And if you remember from the last time we went through, and there's, you know, 3 or 4 different models in each of these areas. So I think what would be interesting for your members is in some of those areas around where there's a healthcare or a social determinant of health organizational engagement, that would be great for them to say, oh, I'm really familiar with the Stanford Chronic Disease Self-Management Program that is happening at, you know, XYZ organization in this way. But these are very particular models, so I think the survey has less to do with community engagement and more in model development.
Okay, and I guess you answered my question very articulately. I want to make sure that that message is what's being received by those community partners. And I don't know that I was specific enough in telling them that, but hearing this today, I can go forward and address that. Because I think oftentimes what happens is those community partners believe that their information will then help inform the way we go about using this demonstration tool. So I think their passion or their willingness to participate is based or predicated on that. And somehow we have to make sure that that narrative that we're giving out to them is consistent with what you just told us here today.
Yes, and I think that has been one of the challenges of how we've talked about this waiver from the very beginning, which is much more like a pot of gold for us to spend to transform things, and that what is in the toolkit, because of the requirements around evidence-based and ability to save those dollars fast enough, and infrastructure investment that will be required, it's going to feel a little more narrow. And yet, I was so incredibly delighted that when we went through all those different models, there was an ACH who've been pitching that as a great way to improve health. So I want to be careful in saying, like, this has also been a from the ground up process. There were 168, 186 projects selected. When you go through and you look at the themes, they're reflected in this structure, as well as a connection point to those models. So it's important to note, like, it isn't as if the healthcare authority was over here in a corner saying, this is what we're going to make regions do. This really has come from the collective ACH movement around the state, and we are now at that pivot point where generative problem solving is over, and we are moving into, this is our best attempts at transforming health with these models, giving regions a choice around sort of where they might fall into. So I agree there's some more communication parts, and it's going to feel harsh to folks who haven't really tracked the nuanced comments being made over the last, I don't know, maybe 6 or 7 months, where you started to get the like, oh, this has got to be across the state. You've got to have some of that commonality in order to show statewide outcomes. Somebody's sawing, I think, in the background.
Does your LOI process include public information meetings for those interested in doing an LOI?
Oh, we certainly could do that.
I mean, it's standard in the RFP world, and it allows you to get in a room with people and see who else is looking to do this.
You bet. That's a great idea.
And the other thing is, within your information that you're going to put out, are you asking the question, who needs to be at the table with you? Are you asking that question? Because then it makes people think, oh, I really need to be looking broader.
Yes, and that would be, as we move into our next activity, that would be an awesome evaluation criteria to highlight and or deepen as a priority level. I will say they've not released even a draft project template, but in the project toolkit, they talk about having binding letters of intent for partners. So this is not like, hey, Dawn, I think it'd be cool if we collaborated on it. Like, you got to be all in as we move through this. So that's a great, from an LOI perspective, to make sure that that's clear. Okay, I want to make sure we get a chance to do some work, but I don't want to leave any unanswered questions.
So just really quickly, can you tell me where Pathways fits? Is it one of the 5?
It's community-based care coordination.
Thank you. Okay.
That was easy. And I totally shut off any other questions tonight. This is your chance to get feedback. So we certainly, if you have other questions, feel free to call, email, in general, and maybe we'll do a weekly blog post of questions and comments that we're getting, so that nobody's stuck without feeling like they didn't have access to information or didn't know. Okay. I had a couple other things, but I think we want to get to evaluation criteria, so we'll send it.
Yeah, so we will make sure to send out, we had some updated slides here on, there we go. On, there has been an update to the toolkit, so we sort of updated our slides to match what had changed in the toolkit. I will send that out with the blast so you guys can look through all that. But what we really want to get to today is this activity for the project selection criteria. So like Allison mentioned, next week the board is going to be meeting to look over this draft criteria, and I'm hoping that we can use today to generate some feedback from the Leadership Council that I can give to the board to help inform their discussion. There are, throughout the room, sets of criteria in little stations. So we're going to have 4 stations here at each round table. And I'm going to throw up a list of questions that should prompt some feedback. The idea would be we have sticky notes and pens out everywhere. You guys can just take the sticky notes and post them up next to the criteria that's up on these even larger sticky notes. We'll then collect that and generate this report, and we'll share it out with all of you and to the board. A really exciting thing that I'm happy to share is that as we develop this criteria, so next week the board is really going to be talking about, you know, do we have all of the criteria we need? Is anything missing? And also, what's sort of the point value for each of these criteria? We have 14 criteria right now. It stands to say that some of them are going to be more valuable or sort of be of greater importance to whether or not a project would actually be successful. And how we weight those, we'd also really like your feedback on. So after we spend some time doing sort of a pop around to the different stations to give some feedback, everyone is being handed right now by Alex and Justin what's sort of a scorecard for each of the projects, and we're asking you to rank them between 1 and 3, sort of giving them what you would say the weight of that criteria is. So does it feel extremely necessary that a proposal shows that it can cover this criteria, or is it maybe, maybe it's not as important? We could be flexible and sort of work around that if this proposal wasn't as strong in this area of criteria. Another update is once the board gets all of this criteria finalized, we are going to be putting it into a software that the Spokane Regional Health District uses to make decisions using really like data-driven and also a very unbiased approach. And I'd love to invite Tony really quickly to make some comments about this really neat software, because our goal is that after the board has finalized this criteria, next month in the April Leadership Council, we're actually going to show you a demonstration of this criteria, of the software and how it will help us make this decision, and also really keep it transparent for everybody else as we move forward.
Thanks, Hadley. The software is called Logical Decisions for Windows, and it is a phenomenally helpful decision support software. And for any of you who might be interested in seeing a touch of it, I did bring my Service Pro over, and I can show you how we have used this at the Health District. You establish your own criteria through which you want to compare options. And it can be as challenging as what we have done at the Health Department, which is looking at how do we spend or divide the general fund dollars we have amongst a variety of very meaty programs. How do you choose how much goes to each one? It could be as simple as helping you decide where do you want to go for a vacation or what kind of a car to buy based on criteria you set. So you establish the criteria, which we will be able to do here, and what this exercise will help us look at. Then this software simply says you then score the various what are called alternatives against that. Everybody gets a chance to score it independently. The software then turns around and says, based on your values or your criteria and the way you scored it, here's how they rank. So it's very objective and incredibly helpful for the work that we've done. So it's here, and happy to share it with anybody afterwards if you have a desire to see it.
Thanks, Tori. So I'm going to give some instructions for the folks in the room first, and then we also have an option for people on the phone to participate. So in the room, as I said, we have these 4 stations, each of the 4 round tables. If you could go ahead and self-divide yourself into 4 groups, I'm going to be the timer. So I'll give you about 7 minutes at each table to take a look at this criteria and leave any feedback on the sticky notes. After we get through each of the stations, we have another activity. I'm going to ask all of the groups to just sort of pop a squat at whatever table they're at and look at the whole list of criteria, which you should all have in your hands now. Go ahead and look at the whole thing comprehensively. Do you think there's anything missing that we need to possibly add as a criteria? Are there any descriptions that need clarification? And then go ahead and sort of rank how you would weight each of these different criteria on the scorecard handout that we gave you. So I'm going to go ahead and say people in the room can break. And I will let you know when it's time to rotate to the next group. Now, if you are on the phone, we are about to mute the mics inside the room so that you won't hear any of the chatter going on. And Justin is going to move out into another room so that he can lead you through this same process. If you're attending via webinar, you should be able to download the project selection criteria one sheet that's listed in the materials in the chat box. And if you are just attending by phone, Justin will do his best to walk you through it. Thank you all.
Yeah, thank you. Yeah, I'll love to hear each topic.
Just moved us as phone attendees to a different room, and we shouldn't be hearing anyone from the conference center. So can everyone hear me? Okay, no worries, Jenny. We'll talk to you later.
Hi, this is Carly. I'm having difficulty finding the materials tab.
Okay. If you go to your GoToTrain control panel, it is in between the audio section, the webcam section, the polls and test section. If you can find it, it says materials. Click on the arrow and it should give you a tray of materials.
Huh. Let me see if I can grab someone who can better get this than me.
Okay, no worries.
If you guys want to go ahead while I figure this out, you can feel free. I know that there's not, there's limited time.
Carly, it looks like it's just you and me for now. So.
Oh,
No
Peter's
worries.
not, I mean, I see him on. I had to, oh, nope, it's literally just you and me.
No worries if you can't access them. We will email out the scores chart and the project statements.
Okay.
But are there any comments that you'd like me to take note of and make sure that the rest of the group knows?
I don't think so without having seen the criteria list.
Sure. So why don't I'll just read through the list.
Okay.
Then I'll just take your initial thoughts about it. So we have a list of about 15 different criteria here. We are tracking this problem statement, how well does the project proposal provide current local statistics?
It's actually kind of difficult to hear you. Can you speak closer to the mic?
Oh, sure. Is that a little bit better?
Yes, thank you.
So we have 15 different categories here for project selection. One is around a problem statement asking how well does the project proposal provide current local statistics and other evidence to document the scope of the problem, which is pretty standard.
Mm-hmm.
The other areas look at population, how well the project proposal describe the target population. Another area on health equity. Another on project intervention. So how clearly defined are the proposed multi-sector activities or intervention? And how did the project demonstrate staff organization and partner experience? We have one on outcomes. That's pretty standard as well. Another aspect is how well the project is aligned with the Medicaid transformation project models that are told. Another area is on how scalable is the project, how much collaboration has been involved, and if the organization pitching the project will be ready by January 1st of 2018. The last section is on aligned resources, how this project proposed can leverage federal, state, local, or private resources. And the other is sustainability. So how can the people of this project have a greater return on investment given if it would be funded through the waiver? And the last two is on workforce and track record of leadership. And the track record of leadership says how likely is this project to succeed? Did they have an identified leader identified a challenge?
Does the workforce have anything around what other staff will be needed or something like that?
Is there adequate health workforce available to support? So it's more
Okay.
not so much about the implementation of the project, but for health professionals to carry out the project. But I'll definitely make a note about staffing capacity to build up to the project. That's
Mm-hmm. Sounds good. Yeah, I'm with the Center for Community Health and Evaluation, and we are the HCA's evaluation group for the ACH initiative as a whole.
I remember now. Okay.
Yes. Yeah, we hung out last time.
That's right. Now you're on the other side of it.
I am, and it's still just one person on the other side of it. I mean, it's actually great that even though it was two Leadership Council folks on the line, now it's no one, but that you still did this breakout for those on the phone.
So I suppose that you've been around this work for a while now. I mean, what are some of the gaps that you've just seen?
The gaps in...
For project implementation.
Oh, you know, I think that lots of the ACHs are all in a similar place in figuring out what the evaluation criteria will be for project selection. I can say that I think it's only you and one other ACH that's doing a survey out to the community, so to speak, around where interest is. Other than that, I can't really speak to others. That's sort of what's top of mind right now.
Well, you know, I have the luxury of looking at the project selection criteria here, and I think it's simple enough that if you would have a community board, is what Allison to go through this project was initially. I think it's fairly simple to follow along.
Yeah.
My worries is that are there gaps that the waiver requires that we haven't found yet, possibly heard of yet?
Sorry, you cut out. Again, you're worried that there are things that you're just not really thinking about. I think that's something that's come up, and this came up at the convening as well, in terms of what are the data capacity needs for ACHs to both have that evidence that you were talking about to be able to speak to what is the most appropriate target audience, in addition to what outcomes will need to be tracked at the ACH level and what will be tracked by the state at the ACH level. So that latter part is something that's a conversation that's kind of ongoing. But understanding, and I'm not sure if this is within the criteria that you laid out, but understanding if there are specific data needs, data infrastructure analysts, any of those sorts of things within the project that you would want people to lay out for the letter of interest and submission process.
Absolutely. I'm taking notes here.
Okay. Let me think.
Going back to your staffing and the staff capacity issue you brought up, what's the best way people are pitching the projects? What's the best way of gauging whether they have staff capacity or not? But how do we, as ACH, measure what is adequate staff capacity and where the ACH can come in with that staff as well?
Yeah, I think that there could be questions around, especially if it's an existing project that they want to spread, being able to say we have, like, that they have the ability to project manage or something like that, but they need more people to implement. So that's when the ACH could say, this is a great project, but we need to figure out if there are more community health workers that can be added to this network to make this program or this project spread across a broader part of our region. Yeah, I guess it comes down to also how will BHT do the project management for all of these projects, and then the implementation will be done by separate organizations, or sort of like how Omar is working on the pathways, the implementation comes from staff within BHT. That's something that, in terms of for BHT, I'm not sure the answer which way that goes.
Right, right. I think once we hear back from our council board, they'll give direction as appropriate. So. Okay, it looks like we're getting back together in the conference room.
Okay.
I'm going to press for the time being, and we'll unmute when we get back in.
Okay.
Okay, thanks, Carly.
Yeah, thank you. Good talking to you.